Welcome to RadOnc Smart Review Physics Edition. This is actually our last session in the main physics series.
Hard to believe we've covered so much ground.
Definitely. So today we're rounding out our imaging tour. We're going to really dig into the physics of positron emission tomography, that's PET and ultrasound, or US, and crucially, how they fit into radiation oncology.
Right. We've done CT, essential for dose calculation with its electron density info, and MRI, which is just unbeatable for soft tissue contrast when you're contouring.
Exactly. And PET and ultrasound, they bring something different to the table, things that are complementary. PET shows us function, right? Metabolic activity.
While ultrasound gives you those real-time anatomical views using sound waves.
Yeah.
Totally different physics.
And often it's the combination that's so powerful. I mean, think about how often we order a PET CT.
Oh, constantly. It's standard practice for so many sites.
You get that metabolic hotspot from the PET overlaid directly onto the detailed anatomy and density from the CT. That fusion is, well, it's what makes PET so useful for us.
Precisely. It's not just seeing some anatomical abnormality. You're seeing something that's metabolically active, which, that's often the critical piece you need for staging or figuring out exactly what to treat.
Or what not to treat sometimes.
That's a good point. And then ultrasound, that real-time aspect, is just indispensable for procedures where you absolutely need to see what you're doing while you're doing it.
Okay, so let's dive into the physics. Maybe start with PET.
Sounds good. So PET, fundamentally, it's a nuclear medicine technique. The goal is to see where a specific radioactive tracer goes in the body, and that tells us about metabolic processes.
And it starts with giving the patient that tracer.
Right. You inject them with a molecule the body normally uses, like glucose, but it's been tagged, labeled, with a specific type of radioactive isotope, one that emits positrons.
The workhorse for us in oncology is 18F fluorodeoxyglucose, FDG.
18F FDG, exactly.
And the idea is FDG looks a lot like glucose to the body's cells.
Yep. So cells that are really metabolically active, and that includes many types of aggressive cancer cells, they gobble up glucose like crazy. They see FDG, think it's glucose, and take it right up.
But there's a trick, right? It gets stuck.
That's the key. Unlike regular glucose, which gets fully metabolized, FDG gets phosphorylated that first step, but then it can't proceed further down the metabolic pathway. It just accumulates inside those highly active cells.
So the bright spots you see on a PET scan correspond to areas where lots of FDG has built up because those cells are working overtime metabolically.
Correct. And the radioactive tag that makes this whole thing visible is fluorine 18. 18F, that's the atom that emits the positron.
Okay, and why 18F? Is there something special about its property?
Well, it hits a sweet spot, especially for whole body imaging. Its half-life is about 110 minutes.
Just under 2 hours.
Right. Which is, long enough to actually make the FDG in a cyclotron, do quality control, ship it to the clinic if needed, inject the patient.
Let it distribute in the body, which usually takes about an hour.
Exactly. And then get them into the scanner and acquire the images. It all fits nicely within a few half-lives, but it's also short enough that the radioactivity decays away reasonably quickly after the scan, minimizing the patient's dose.
Makes sense. Okay, so the 18F is in the cell. What happens next? The core physics bit.
Okay, so the 18F nucleus is unstable. It undergoes a type of radioactive decay called beta plus decay. In this process, a proton inside the nucleus transforms into a neutron.
And to conserve charge.
It emits a positron that's the antimatter particle of an electron. Same mass, opposite charge. We denote it beta plus. The fluorine 18 becomes oxygen 18 in the process.
So this positron gets ejected from the nucleus. What happens to it? Does it travel far?
Not very far, actually. It gets emitted with some kinetic energy, and it travels a very short distance within the tissue, bumping into atoms, scattering, losing energy along the way.
How short are we talking?
Depends on the initial energy and the tissue density. But for 18F, the average distance, the positron range, is typically less than a millimeter in soft tissue. Maybe up to a few millimeters for the higher energy ones. It's quite localized.
Okay, so it travels a tiny distance, slows down, and then what?
And then, once it's lost most of its kinetic energy and it's practically at rest, it inevitably encounters a nearby electron, just a regular electron in the tissue.
Matter meets antimatter.
Exactly. And they annihilate each other. Poof. They completely disappear, and their total mass is converted into pure energy, according to Einstein's E16c.
And this energy comes out as photons.
Precisely. 2 gamma photons, to be exact. And because of conservation of energy and momentum, each photon carries away exactly half of the total rest mass energy of the electron-positron pair.
Which is 511 key. I remember that number.
That's the one. 511 kilo electron volts. Each photon has exactly 511 PV of energy, which corresponds to the rest mass energy of an electron, or a positron.
Okay, 2 photons, both 511 keV. Is there anything else special about them?
Yes, absolutely critical for imaging. They fly off in almost exactly opposite directions, 180 degrees apart.
Ah, okay. Like they're pushing off from each other.
You can think of it that way. That back-to-back emission is the cornerstone of PET imaging. So the key takeaway physics point. PET relies on detecting pairs of 511 keV annihilation photons traveling 180 degrees apart.
Right. And that's what the scanner is designed to look for.
Exactly. The patient lies inside this ring, or multiple rings, of detectors. These detectors are typically scintillating crystals, things like BGO, LSO, LASO, materials that give off a tiny flash of light when they absorb a gamma photon.
And that light flash is detected.
Yeah, it's detected by a photomultiplier tube, or maybe a solid-state photodiode, which converts that tiny light flash into an electrical pulse.
So the scanner sees individual photon hits, but you said it looks for pairs.
Right. The clever part is the coincidence detection circuitry. The system isn't just counting every 511 key photon that hits any detector. It's specifically looking for 2 detectors on opposite sides of the ring that register a 511 key photon hit at the same time.
How simultaneous does it have to be?
Very simultaneous, within a very narrow time window, usually just a few nanoseconds. If 2 photons hit opposing detectors within that tiny window, the system counts it as a coincidence event.
And what does that coincidence event tell you?
It tells you that the annihilation event, the place where the positron met the electron, must have occurred somewhere along the straight line connecting those 2 detectors that fired in coincidence.
Okay, so you don't know exactly where along the line, but you know it's on that line.
Precisely. That line is called the line of response, or LOR.
Got it. So 1 annihilation gives you 1 LOR.
Yep. And the scanner just sits there and collects millions, even billions of these LORs from all different angles as the tracer decays throughout the patient's body.
And then you need to turn all those lines into an image.
Right. That's where the reconstruction algorithms come in. It's conceptually similar to how CT images are reconstructed from projections, but often more complex for PET. They use sophisticated mathematical techniques, frequently iterative reconstruction methods, to take all those intersecting LORs and figure out the 3-dimensional distribution of where the annihilations were happening most frequently.
And since the annihilations only happen where the tracer accumulated?
The final image gives you a 3D map showing the concentration of the radiotracer and therefore the metabolic activity throughout the body.
So unlike CT or MRI, which show structure, PET shows function.
Exactly. It's a functional imaging modality.
Now, we often talk about SUV values in PET reports, standardized uptake value. What's that about?
Right. SUV, it's an attempt to make the PET image data more quantitative, or at least semi-quantitative. The raw image just shows relative concentrations, but SUV tries to normalize that.
Normalize for what?
Primarily for the amount of radioactive tracer injected and the patient's body size, usually their weight. The idea is to get a value that reflects the tissue's tracer uptake relative to the average uptake if the tracer were distributed evenly throughout the body.
Okay, how is it calculated, roughly?
The common simplified formula is SUV equals the measured radioactivity concentration in a region of interest, say in units like kilobecquerels per milliliter, divided by the total injected dose, usually in megabecquerels, and then multiplied by the patient's weight in kilograms.
Let me make sure I heard that right. SUV equals tissue activity injected dose, patient weight.
That's the basic form. Sometimes lean body mass or body surface area is used instead of total weight, which can be a bit more accurate, especially comparing patients of very different builds.
And what does the number mean, like an SUV of 8 versus 2?
Generally, a higher SUV value suggests higher tracer concentration in that tissue, which implies higher metabolic activity. So an SUV of 8 in a lymph node is much more concerning for malignancy than an SUV of 2.
But you said semi-quantitative. What are the caveats?
Oh, there are many. SUV is really useful, but you have to be careful. It's not a perfect measure of metabolic rate. It can be affected by lots of things.
Like what?
Well, the time between injection and scanning is critical uptake changes over time. The patient's blood glucose level at the time of injection matters hugely. If their blood sugar is high, the sugar competes with FDG for uptake into cells, lowering the tumor SUV.
Ah, hence the fasting requirement before a PET scan.
Exactly. Also, patient motion during the scan can blur the image and affect SUV. Even the specific reconstruction parameters used by the scanner software and the type of scanner itself can influence the final SUV numbers.
So comparing SUV values absolutely requires consistent protocols. You can't just compare an SUV from one hospital with another taken under different conditions.
You really can't. It's best used for tracking changes within the same patient scanned on the same scanner using the same protocol, like comparing pre-treatment and post-treatment.
Okay, that's a really important clinical pearl. So how do we actually use PET, usually PET-CT, in radiation oncology?
Well, several key ways. First, diagnosis and staging. PET is incredibly sensitive for detecting metabolically active disease.
Finding primary tumors, or maybe more often, finding metastases that weren't obvious on anatomical imaging alone.
Exactly. Especially lymph node mets, or distant metastases. Think about lymphoma, lung cancer, head and neck cancer, esophageal, colorectal, melanoma. PET-CT is often standard for initial staging. It can find tiny spots of disease in nodes or organs that look perfectly normal on CT.
And finding those can completely change the patient's stage, right? Which changes prognosis and the whole treatment plan.
Absolutely. It might shift someone from potentially curative local treatment to needing systemic therapy or maybe palliative radiation instead of aggressive treatment. It's hugely impactful.
Okay, staging is one big use. What else?
Target volume delineation. This is huge for RT planning. For tumors that avidly take up FDG, the PET scan helps us define the gross tumor volume, the GTV.
How does it help refine the GTV compared to just using the CT or MRI?
It can show the metabolically active part of a mass. Sometimes a CT shows a large, complex mass, maybe with central necrosis or surrounding inflammation. The PET can highlight just the viable active tumor within that, which is what you really need to target with the highest dose.
So it helps separate tumor from non-tumor, essentially.
Yes, or differentiate tumor from treatment-related changes like fibrosis or inflammation, which can be really tricky on CT MRI alone, especially after prior treatment.
And we contour this GTV PET directly on the fused PET-CT images.
Typically, yes. Use the CT for the underlying anatomy and bony landmarks, and the PET overlay helps you define the metabolically active extent of the tumor and involved nodes. It's standard practice now for planning many head and neck, lung, lymphoma, and esophageal cases, among others.
Okay, staging, target definition, any other major uses?
Treatment response assessment, especially for FDG-avid tumors treated with chemotherapy or chemoradiation.
How does that work?
Because PET measures metabolic activity, you can sometimes see a decrease in FDG uptake, a drop in SUV, indicating a metabolic response to treatment before the tumor actually starts to shrink noticeably on CT or MRI.
So it can be an earlier indicator of whether the treatment is working.
Potentially, yes. A significant drop in SUV post-treatment is generally a good prognostic sign. Conversely, persistent high uptake might suggest resistant disease. This is used routinely in lymphoma response assessment, DeVille criteria, and explored in other cancers too.
Sounds powerful, but are there downsides or limitations to PET?
Definitely. We mentioned the spatial resolution isn't as good as CT or MRI, typically around 4 to 6 millimeters best case.
Yeah.
You won't see super fine anatomical details on the PET image itself.
That's why the CT fusion is so vital.
And the big one clinically. FDG uptake isn't tumor specific. Lots of things besides cancer can cause hotspots.
Like
Infection and inflammation are major culprits. An abscess or active inflammatory process can be intensely FDG avid. Also, some normal tissues have high uptake. The brain always does, the heart muscle often does, active muscle.
so you need to correlate clinically and with the CT findings. A hotspot in a weird place might be inflammation, not METs.
Absolutely. Clinical context is key. And patient preparation, like fasting and resting before the scan, helps minimize physiological uptake in muscles.
Any other limitations?
Well, there's a radiation dose. The injected tracer gives the patient a dose, typically around 5 to 10 millisieverts for an FDG scan. It's not huge, but it's additive to other imaging doses, and it requires specialized equipment, cyclotrons for many tracers, and is relatively expensive.
Okay, so that's a good overview of PET. Positron emission, annihilation, 511 keV photons, coincidence detection, LORs, reconstruction, SUV, and its uses in staging, targeting, and response, with caveats about resolution and specificity.
Nicely summarized. Ready to switch gears to sound waves.
Let's do it. Ultrasound. Completely different beast.
Totally different physics. Ultrasound uses high-frequency sound waves. Remember, sound is a mechanical wave. It needs a medium, like tissue, to travel through. It can't travel in a vacuum like light or X-rays.
And these waves have properties like frequency, wavelength, and velocity.
Exactly. And they're related by that fundamental equation. Velocity, v, equals frequency, f times wavelength. Lambda, v,
So an ultrasound just means the frequency is really high, right?
Right. Higher than humans can hear. Human hearing typically tops out around 20,000 hertz or 20 kilohertz, kilohertz. Medical ultrasound uses frequencies way above that, typically in the range of 1 to 15 megahertz, megahertz. Millions of cycles per second.
Wow. And how do we generate and detect these high-frequency sound waves?
That's the job of the transducer, the part you hold against the patient. Inside the transducer are special materials called piezoelectric crystals.
Piezoelectric. What does that mean?
It means they have this amazing property. They can convert electrical energy into mechanical energy, sound waves, and they can convert mechanical energy, returning sound waves, back into electrical energy. It works both ways.
Wow.
When the ultrasound machine applies a voltage pulse across these crystals, they physically deform or vibrate very rapidly at a specific frequency. That vibration pushes on the surrounding tissue, creating the pulse of ultrasound waves that travels into the body.
Okay, so voltage in, sound wave out.
Yep. Then the transducer waits and listens. When echo sound waves reflected back from tissues inside the body hit the transducer, they make those same piezoelectric crystals vibrate again.
And that vibration creates
a small electrical voltage or signal. The ultrasound machine detects this signal, amplifies it, and processes it to form the image. So the transducer is both a speaker and a microphone, essentially.
Okay, so it sends a pulse, listens for echoes. What determines whether an echo comes back?
It all comes down to a property of the tissue called acoustic impedance, usually denoted by the letter Z.
Acoustic impedance?
Yeah.
What is that?
It's basically a measure of how much resistance a tissue presents to the passage of sound waves. Think of it like how hard or easy it is for sound to travel through it. It's calculated as the product of the tissue's density, rho, and the speed of sound within that tissue, V. So Z, EQV.
And different tissues have different densities and sound speeds.
Yes. The speed of sound varies quite a bit. It's relatively slow in air, around 330 meters per second. It's around 1,540 meters in most soft tissues, which is the average value the machine assumes. It's faster in denser materials like bone, maybe around 4,000 meters.
So different tissues have different Z values. How does that create an echo?
An echo is generated whenever the ultrasound pulse encounters a boundary, an interface, between two tissues that have different acoustic impedances. Let's say tissue 1 has an impedance Z and tissue 2 has Z.
Okay.
When the sound wave hit that boundary, part of its energy is reflected back towards the transducer as an echo, and the rest is transmitted deeper into tissue 2.
And does the strength of the echo depend on how different Z and Zers are?
Exactly. The bigger the difference in acoustic impedance between the two tissues, the stronger the reflection, and the brighter that interface will appear on the ultrasound image.
Ah, okay. So if two tissues have very similar Z values,
You get a very weak echo, or maybe none at all. The boundary will be hard to see.
but if the difference is huge, like between soft tissue and bone or soft tissue and air,
Then the impedance mismatch is massive. Air has extremely low impedance. Bone has very high impedance compared to soft tissue. So at those interfaces, you get almost total reflection of the sound wave.
which means a very bright echo.
A very bright echo, yes, but also, critically, very little sound energy gets transmitted past that interface.
Ah, that's why you can't really image things behind bone or air.
Precisely. The sound just bounces right back from the surface of the bone or the air pocket.
Yeah.
You get acoustic shadowing behind bone, and you just can't penetrate air-filled structures like the lungs or bowel gas effectively. That's a fundamental limitation.
Okay, so impedance differences cause reflections. Does anything else happen to the sound wave as it travels?
Yes, it also gets weaker due to attenuation. Attenuation is the gradual loss of sound energy as it propagates through tissue.
Why does it lose energy?
Two main reasons. Absorption, where the sound energy is converted into heat within the tissue, and scattering, where the sound waves bounce off tiny structures within the tissue in various directions, so less energy continues straight ahead.
And does attenuation depend on the sound wave itself?
Absolutely. And this is probably the most important practical concept in ultrasound physics. Attenuation increases significantly with increasing ultrasound frequency.
Okay, higher frequency means higher attenuation. What does that mean for imaging?
It leads to a fundamental trade-off. A direct conflict between image resolution and how deep you can see into the body, the penetration depth.
Or break that down for me. Let's say I use a high-frequency transducer like the 10 or 12 megahertz.
Okay, high frequency. That means the wavelength is short. Short wavelength is good for resolution. Specifically, it gives you better axial resolution.
Axial resolution? What's that?
That's your ability to distinguish between two small objects that are located close together along the direction the sound beam is traveling, one behind the other. Shorter wavelength means you can resolve finer details along that axis. You get a sharper, clearer image.
Okay, high frequency, high resolution, sounds great. What's the catch?
The catch is that high attenuation. Because attenuation is so much higher at 12 millihertz compared to, say, 3 millihertz, those high-frequency sound waves get absorbed and scattered very quickly. They lose their energy rapidly.
So they can't travel very far into the tissue.
Exactly. They don't penetrate deep enough to create usable echoes from structures far below the surface. So high-frequency transducers have limited penetration depth.
Okay, so high frequency gives great detail, but only for things close to the surface.
Perfect. That's why you use high-frequency probes, maybe 7 to 15 millihertz, for imaging superficial structures like the thyroid, breast lumps, tests, superficial nodes, skin lesions. You need that detail, and penetration isn't an issue.
All right, now what if I need to see something deep, like the liver or the kidneys in the abdomen or the uterus?
Then you have to use a lower frequency transducer, maybe in the 2 to 5 megahertz range.
Okay, low frequency. What happens now?
Low frequency means a longer wavelength. Longer wavelength means worse axial resolution. Your image won't be as sharp, the details won't be as fine.
That's the downside. What's the upside?
The upside is much lower attenuation. Because attenuation is less at lower frequencies, the sound waves can travel much deeper into the body before they become too weak. So low-frequency transducers give you greater penetration depth.
So you sacrifice some resolution to gain the ability to see deeper structures?
That's the trade-off, exactly. You have to use lower frequencies for abdominal imaging, pelvic imaging, obstetrics. You need that penetration.
Okay, so let's try to summarize that trade-off. It's crucial.
High frequency equals high resolution but low penetration.
And low frequency equals low resolution but high penetration.
Got it. That's the mantra you have to remember when choosing an ultrasound probe or evaluating an image. Did they use the right frequency for the job?
Okay, that makes sense. So we send a pulse. It reflects off interfaces based on impedance differences, and we choose the frequency based on depth versus resolution needed. How does the machine actually build the picture?
It uses the pulse echo principle. Send out a short pulse, then listen for returning echoes.
And how does it know how deep the echo came from?
Based on timing. It measures the time it takes for the echo to return to the transducer after the pulse was sent out. Since sound travels at a relatively constant speed in soft tissue that assumed 1,540 meters per second, a longer return time means the echo came from a deeper structure.
Simple geometry, basically. Time equals distance speed.
Yep. The machine calculates the depth, distance speed time too, because it's a round trip, for every echo it receives.
And then it displays this. How does it make the grayscale image we usually see?
That's called B mode, or brightness mode. It's the standard anatomical image. For each echo received, the machine calculates its depth based on time and determines its strength or amplitude.
And the amplitude determines the brightness.
Exactly. The stronger the echo, meaning a bigger impedance difference at the interface, the brighter the pixel corresponding to that depth will be on the screen.
So really strong reflections, like from bone or maybe gas, look bright white.
Right. Those are called hyperechoic. Tissues that reflect moderately, like solid organs, appear as various shades of gray.
And what about things that don't reflect at all, like fluid?
If there's no impedance difference, or if the sound just passes through without reflecting, no echo returns from that region. The machine displays those areas as black. We call those anechoic, like the fluid inside a simple cyst or in the bladder or inside blood vessels.
Okay, B mode gives us the anatomical map in grayscale. Are there other modes?
Yes, though B mode is the main one for anatomical imaging. There's A mode, amplitude mode, which is mostly historical now. It just showed a graph of echo, amplitude versus depth along a single line.
Okay.
Then there's M mode, or motion mode. It repeatedly sends pulses along one line and displays how the positions of reflecting structures along that line change over time. It looks like a wavy line graph.
Where would you use M mode?
It's essential in echocardiography for looking at heart valve motion or measuring chamber dimensions accurately over the cardiac cycle.
Got it. Any others?
The other big one is Doppler ultrasound. This uses the Doppler effect to detect motion, primarily blood flow.
The Doppler effect, like the pitch change from an ambulance siren.
Exactly the same principle. If the sound waves reflect off something moving towards the transducer, like red blood cells, the returning echo has a slightly higher frequency. If they reflect off something moving away, the echo has a slightly lower frequency.
And the machine can detect this tiny frequency shift.
Yes. And the magnitude of the frequency shift tells you how fast the blood is moving. And the sign of the shift, higher or lower, tells you the direction relative to the transducer.
And this is shown with colors.
Often, yes. Color Doppler overlays a color map onto the B mode image. Typically, red means flow towards the transducer, blue means flow away, and the brightness of the color indicates the relative velocity. Gives you a quick map of where blood is flowing.
Are there other Doppler types?
Yes, pulsed wave PW and continuous wave CW Doppler give you more quantitative information. They produce a spectral waveform, a graph showing the range of blood velocities present over time within a specific sample volume, PW, or along the entire beam, CW. Cardiologists and vascular techs use this extensively, sometimes useful in oncology to assess tumor vascularity, though not a primary RT tool.
Okay, quite a range of information from sound waves. Now let's bring it back home. How do we actually use ultrasound in radiation therapy? You mentioned it's not a primary planning tool like CT.
Right. Its role in external beam planning is pretty limited, mainly because of those issues we discussed: operator dependence, poor penetration through bone and air, and difficulty getting quantitative data for dose calculation.
So where is it essential?
Its main niche is real-time guidance during specific procedures, leveraging that ability to see anatomy instantly.
And the classic example is?
Prostate brachytherapy. It's absolutely fundamental there. We use transrectal ultrasound, or TRUS.
Okay, explain that workflow.
Well, first, you do a TRUS volume study, usually before the implant day. The physician uses the probe in the rectum to acquire a series of transverse images through the prostate. The planning system reconstructs these into a 3D model of the prostate, urethra, and rectum. This is used for treatment planning, figuring out where the radioactive seeds need to go.
And then during the actual seed implant procedure?
During the implant, the TRUS probe stays in place, providing continuous real-time imaging. The physician uses a template grid attached to the probe. As they insert each needle carrying the seeds toward the prostate, they watch its path live on the ultrasound screen.
So they can see exactly where the needle tip is relative to the prostate boundary and the planned position.
Precisely. They guide the needle to the correct location based on the plan, deposit the seeds, and withdraw. Repeat dozens of times. TRUS makes that level of accuracy possible in real time. It's a perfect marriage of imaging and intervention.
That's a great example. Anywhere else US might pop up?
It can sometimes be useful for localizing superficial things, maybe helping to mark out a small skin lesion before electron planning, or guiding a biopsy of a superficial node. But these are less common roles compared to TRUS for brachytherapy. It's not typically used for daily setup guidance in external beam like CBCT or MV imaging.
Right, because of those limitations, operator skill needed, can't see through bone or air well, doesn't give density info.
Exactly. Its strengths lie in that real-time visualization for procedures, especially in the pelvis or for superficial structures.
Okay, that clarifies its role nicely. Shall we try to crystallize some key clinical pearls for both PET and ultrasound? Things you absolutely need to remember.
Good idea. High-yield points.
Pearl number 1 for PET. Remember, it uses positron emitters like 18F FDG. It detects coincident 511 Keev annihilation photons flying off 180 degrees apart. That's the signal.
And it images metabolic activity, semi-quantified by SUV, almost always fused with CT for anatomical localization and planning. Maybe a mnemonic like Pete 511 at 180 degrees for FDG, links the energy, angle, and common tracer.
Nice. Okay, pearl number 2 for ultrasound. It uses high-frequency sound, way above hearing, 20 kilohertz. The transducer, with its piezoelectric crystals, sends pulses and receives the echoes.
And those echoes are generated at interfaces between tissues with different acoustic impedance, Z, which is density times sound velocity, Z equals SF.
Pearl 3, the big ultrasound trade-off. High frequency gives you high resolution but low penetration.
And low frequency gives you low resolution but high penetration. You must choose the right frequency for the depth you need to image.
Pearl 4, ultrasound B mode is the standard grayscale image. Brightness depends on echo strength. Depth depends on echo return time, assuming that constant 1540 meters speed in tissue.
And Pearl 5, summing up the RT roles. PET CT fusion is a workhorse for staging and target definition in many cancers. Ultrasound's primary role is real-time guidance, especially TRUS for prostate brachytherapy. Less used for routine EBRT planning or delivery.
Got it. Those are excellent summaries. Maybe let's try a quick clinical scenario, sort of like a mini case to apply this.
Sure.
Okay, imagine you have a patient who finished chemoradiation for, say, locally advanced head and neck cancer a few months ago. On their follow-up CT scan, there's some fullness or maybe subtle enhancement in one area of the treated neck, but it's hard to tell if it's just post-treatment inflammation, scar tissue, or if it's residual or recurrent tumor. What imaging study would be most helpful, and what's the physics principle you're relying on?
Yeah, that's a super common and often difficult clinical question. The go-to study here would almost certainly be a PET CT scan,
And why PET-CT?
because you need that functional information PET provides. Both scar tissue and active tumor might look abnormal on CT. But active tumor cells are typically highly metabolic and will avidly take up FDG, showing up as a hotspot with a high SUV on the PET scan. Scar tissue or mature fibrosis should be metabolically quiet, with low or no FDG uptake.
So you're fundamentally relying on the difference in glucose metabolism between viable tumor and inactive post-treatment tissue, which PET visualizes via FDG uptake.
Exactly. The PET tells you if that questionable area on CT is metabolically active or not. The fused CT part, of course, tells you precisely where that activity or lack thereof is located anatomically. It directly addresses the clinical question. Is there active disease here?
Perfect illustration. Understanding the physics, what each modality actually shows you, lets you choose the right test.
Okay, ready for a board blitz.
Let's do it. Fire away. Question 1. The two photons detected in coincidence by a PET scanner originate from which physical process? A. Compton scattering of primary gamma rays from the tracer. B. Pair production caused by high-energy beta particles. C. Annihilation of a positron emitted by the tracer with an electron. D. Bremsstrahlung radiation produced as positrons slow down.
Okay, we covered this. Positron emitted, travels short distance, meets electron, they annihilate, producing the two photons. So that's answer C.
Correct. C. Annihilation of a positron emitted by the tracer with an electron. That annihilation is the source of the coincident 511 keV photons PET detects.
Okay, next.
Question 2. A physician wants to use ultrasound to get a high-resolution image of a superficial thyroid nodule. Which transducer frequency would be most appropriate? A. 3 megahertz. B. 5 megahertz. C. 7 megahertz. D. 12 megahertz.
Superficial thyroid nodule. Key words. Superficial high resolution. That points directly to high frequency. Of the choices, 12 megahertz is the highest. So D.
Correct. D. 12 megahertz. For superficial structures where penetration isn't the main concern, you use the highest available frequency to maximize spatial resolution.
Makes sense. Keep them coming.
Question 3. The standardized uptake value, or SUV, calculated from an FDG PET scan is primarily intended to provide a semi-quantitative measure of A. Tissue electron density. B. T2 relaxation time. C. Regional blood flow. D. Glucose metabolic activity.
Good. SUV from FDG PET. FDG mimics glucose, so SUV reflects glucose uptake and metabolism. That's answer D.
Correct. D. Glucose metabolic activity. SUV attempts to normalize tracer concentration, which for FDG reflects glucose metabolism, often elevated in tumors.
All right, last one.
Last one. Question 4. Ultrasound waves are strongly reflected at an interface between soft tissue and air, primarily because of the large difference in A. Temperature. B. Acoustic impedance. C. Electrical conductivity. D. Shear modulus.
Soft tissue to air? That's a huge mismatch. We've said echoes happen due to differences in acoustic impedance, Z. Air has very low Z, tissue has much higher Z. So the large difference in Z causes the strong reflection. Answer B.
Correct again. B. Acoustic impedance. Strong reflections occur at boundaries with large differences in acoustic impedance. Z equals density velocity.
Whew. Pass the blitz.
Nicely done. So just to wrap things up then, we've covered PET, its physics based on positron annihilation, coincidence detection of those back-to-back 5 on 11 keV photons, how SUV gives us a metabolic snapshot, and its huge role in staging and target definition using PET-CT.
And then ultrasound based on high-frequency sound waves, piezoelectric transducer sending and receiving, echoes generated by acoustic impedance differences, and that crucial trade-off between frequency, resolution, and penetration.
And we've seen how they fit into our world. PET-CT is really integral to modern planning for many sites, while ultrasound shines in real-time procedural guidance, especially for prostate bracket therapy, even if it has limitations for routine external beam work.
Absolutely. And really understanding the why behind these images, the physics principles, it's just so fundamental. It helps you interpret them correctly, understand their strengths, know their limitations, and ultimately use them in the safest and most effective way for patient care.
Couldn't agree more. And with that, well, that's a wrap on our main RadOnc Smart Review Physics series. We've gone from basic interactions all the way through machines, planning, brachy, safety, and now finishing up imaging. It's been quite a journey.
It really has. Hopefully it provides a solid foundation or a good review for everyone listening, though you know the joke, right?
Which one?
They say the hardest part about radiation physics isn't learning it for the boards. It's remembering any of it 6 months after the boards.
That is painfully true. You'll be sitting in clinic trying to remember, was that annihilation or pair production? Was it 180 degrees or 90? Did SUV stand for standard uptake value or seriously unsure value?
Exactly. Hopefully, revisiting these concepts helps make them stick a bit better. Repetition and clinical application are key.
Definitely. Well, for more practice, especially gearing up for orals, you can find complete practice oral boards at radoncsmartlearn.com.
And keep an eye out for future RadOnc Smart Review sessions covering different areas of oncology.
Thanks so much for joining us throughout this physics series.